Good morning. It is August 3rd, 2023. I'm Dr. Duke Majan and CEO and founder of the Duke Spine Institute. Our patient is here today with back pain, and he has several diagnoses. One of them is sacroiliac joint pain on the left side. We've done our Duke plasma rhizotomy with Dr. Patel already at L3-S1, at the sacrum. Now I am going to be performing the Duke laser disc repair. We're going to start with accessing L3-S1. The L3-S1 disc is damaged. It's causing him pain, and he wants to have it repaired with the Duke laser disc repair. He's familiar with the procedure. He's watched our surgeries. He's traveled far to come here for this, and we're going to do his facets as well. So he has AP. He's got pain in his SI joint, which is horrible, his left L4-551 facet joints, and his discs, L3-4-4-5-5-1. The L3-S1 disc is the most degenerated. How you doing?
He's waking up.
Let's keep him comfortable. How's the blood pressure? All right, wonderful. Just lay still, everything's good. All right. So I've got to navigate around this facet at 5-1. It's the hardest one to navigate around. And a lot of surgeons that do endoscopic spine surgery, they won't even try L3-S1. They know how hard it is. AP, where do you feel that?
No pain? He said no pain.
All right, good, no pain. Yep. We're right at the back of that very degenerated disc at 5-1. Let me know if you feel anything at all, Shot. Where do you feel it?
What are you saying? Left side?
In your back or down your leg?
Back or leg? Leg? Feel it down.
How far down your leg?
How far down? Where'd you stop? Is it to your knee or below your knee? Knee.
Mm-hmm. Where do you feel that?
Where do you feel that? Left side? Is it down to your knee? I'm sorry, say it again? Past the knee, he said.
How far down your leg do you feel it? Where?
I'm sorry, what's that? Calf, he said. Calf.
All right, so we're a little close to the nerve root. I want to realign and redirect. Shot. I'm going to try to come in as low as I can. We're limited by the arthritis and the collapse of this disc. Shot. There's a very small window I'm trying to navigate through to get to the actual disc. Where do you feel that? Huh?
Say it again? Nowhere.
All right. Nowhere. I went a little bit lower, like a 0.5 millimeter lower. Where do you feel it?
Left leg.
How far down? What?
Before the ankle.
All right, Jordan, you're not on the lateral view. You don't see the pedicle is off there? That's not an orbital issue, Jordan. Come on, Jordan. What? Jesus, Jordan. Did you forget how to do these procedures? You forgot. Just let me know when you're done, Jordan. You are off about half a degree, and you moved it 2 degrees. No, it's a little better. All right. That's pretty good. See? Now you're kind of paying attention there. Question is, what's going on with that sacrum?
Something deflecting you a little north.
Well, no, the bone spurs are definitely deflecting me. And I'm trying to figure out, I mean, the disc looks good. It's lined up, the pedicle's lined up at 5, but the sacrum looks like it's off. Let's just bring the sacrum into view. So remember where this position is and be prepared to come right back to it. But let's see the sacrum. Shot. Other way. He's got some bad kind of scoliosis between 5 and S1, it seems like. And he's got all that arthritis. You can see the hole is tiny. I just can't get any further south, and I need to be more south. Shot. There's only one other thing I could possibly do. Can't get more medial. Is all. Where do you feel it?
Left calf? Left calf.
Yeah.
Thanks for telling us, sir. Just trying to get the right position for you. Appreciate it.
Shot. Go ahead and so the problem is he's crooked at 5-1, and he's closing off the hole on the left side, making it basically impossible to get into.
Thank you.
I'm going to try one more time. What? I can't hear him.
That's just that's your blood pressure cuff.
Yeah, that's the blood pressure cuff going up. That's
Starting to get
normal.
more alert, you notice it.
We wanted you awake for this part, so I need your help. See, I'm getting forced up again towards the nerve root. See, his arthritis is pushing me up. Give me an AP. Let's see where we are. The lateral view in the pedicle of 5 looks good. It's just that S1 region that's making it really difficult to get to.
Can you approach it lower to higher? Or
No, lower will force it up more. I need to go higher to lower, and I'm as high up as I can go right now.
I see if you go lower to push it. Yeah.
Mm-hmm. Let's see. I think we're off on orbit maybe by just a hair. Just see what we can do on orbit, like literally a hair, half a degree. Try that.
He has some lip.
Other way. Huh?
Looks like there's a lip osteophyte.
No, that's exactly what it is. It's a big osteophyte. It's bone growth. See, I can't get any lower. I just cannot possibly get any lower. Let me see. Where do you feel it? Where?
What part of your body? Left where?
Where do you feel it? I need an answer.
Where are you feeling it? Left leg or left buttock or? Left leg going how far down? This is important. Down to your knee? Ankle?
How far down?
Calf. Keeps reporting the calf.
Mm-hmm. All right. Left back. Right? You feel it in your back? Left back?
Yes.
All right, we're going to give him a little more numbing
I'm
medicine.
gonna give you a little numbing shot here. Left back, you said.
Yeah.
That's where we're working on.
That's where we're working on, my friend. Don't worry. We got you. Yeah, we know. Thank you. Shot. Mm-hmm. You're good. Everything's okay. You're doing great. Shot. I want to come a little lower. He's got a lot of arthritis in his facets. And what it's doing is it's forcing us to go upwards, which we don't want. That looks good. Let's get an AP. All right. Henry, let's show our audience why do discs actually cause pain. Looking good. And by the way, he's got some type of a segmentation anomaly at 5'1". It's not normal. It's mildly abnormal, something he was born with. It almost looks like a spina bifida at S1.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Shot. All right, welcome back. You've seen now how a herniated disc can cause so much pain. And our patient here has more than a herniated disc. All right, very good. You're doing great. We don't want to put him to sleep just yet because we're almost ready to to test his discs. Shot. Shot. All right. Good? Is that better? Yeah. All right. Very good. So, folks, when people have back pain, there's really certain structures that cause back pain. And the most common by far is a disc herniation with specifically a tear. It's called the annular tear. It's part of the disc herniation. And it's the tear in the back of the disc, the annular tear, that actually causes all the pain. Now, this patient, based on his MRI, based on his physical exam, we believe he has back pain at L3-4, L4-5, and L5-S1. Okay? However, L5-S1 is inaccessible. It's impossible to get to. So we're going to be testing L3-4 and L4-5. Are you comfortable? Any pain? I couldn't hear him.
He said no, sir.
All right. All right. I want to make sure you're comfortable. How bad is that on a scale of 1 to 10?
Give us a number. 8.
What's the highest it went to? The highest it went? 8. Is that where you get your back pain every day?
Yes, sir.
All right, we call that concordant. All right, is it better now?
Yeah.
Shot. So, show us the tear, Jordan. This is the tear we're talking about. You guys saw it on the video, the animation. There's a tear in the back of the disc. That's the back of the disc. Show us the front of the disc. There's the front of the disc, okay? And we have been repairing backs of discs, annular tears now for 16 years. And in doing so, we're able to get rid of people's disc pain. But disc pain isn't the only source of pain in people's backs. There are other things that cause pain, like the facet joints. And this patient definitely has facet joint. There you go, Jordan. Thank you. That's the L4-5 facet joint. Circle it. It's a big ball right there, a little behind you. There. And then there's the L5-S1. And we know both of those joints are causing him pain. So we're going to treat those next. But we're going to fix his disc first. We've already fixed his SI joint. Is that better? All right. How bad is that on a scale of 1 to 10? 9 out of 10, all right? Is that where you typically get back pain? All right. Thank you for your help. You've been wonderful. We're going to put you to sleep. I want you to count out loud from 1 to 100. Don't stop till you get to 100. Sweet dreams. Count out loud. Count out loud for me. No, count it from 1 to 100. Keep going. You're doing great. All right, so this patient came to us. We did a telemed because he's found our website, and we did a telemedicine visit, figure out what's causing your pain, what we could do to treat it. And of course, he had options. He could have gone elsewhere. Other doctors were either telling him there's nothing that could be done to fix it, or that they needed more invasive surgeries. But he didn't want invasive surgery. He wanted to come and get the minimally invasive procedures here. So based on his telemedicine visit, I was able to diagnose SI joint pain on the left, facet joint pain on the left, and disc pain in the middle. And so we've already treated the SI joint pain. That wasn't included in our video stream, but Dr. Patel did that first. I'm doing the discs, and then I'm going to do the rest, his facet joints. All right, so we're starting at, what is it, 4-5?
Yes, sir.
Now, the one thing, we were unable to get to 5-1. And the reason is, Jordan, show them the bone there that's blocking us. Henry, you see this? A little back?
Yes, we do.
Yeah. A little posterior, too? All that area, a little posterior, more, that whole area there is, you know, basically big, giant growths of bone from arthritis, from the facet joint, which we're going to treat later. So I was not able to safely get in there. And the problem is, if you can't get into the L5-S1 safely, then you could end up causing damage, which we don't want to do. Shot? So the way I know that we're too close to the nerve, all right? So the problem is, remember, I'm putting a needle. Let me have the needle. Let me have the tube. Okay, you see this needle? I put this needle in that little hole, and I could feel it. It was barely, I had to wiggle it to get it through. That's how tiny it is. And this needle, show them how big the needle is. This needle is, see that? 1 millimeter. You guys see it?
Yes,
1
we do.
millimeter. So if the needle is 1 millimeter, and this tube that's going to follow it into that hole is 7 millimeters, right? 7 millimeters. Then if this tiny skinny needle is bothering the nerve root, what do you think this is going to do? A lot worse. That's why we're not moving forward with L5-S1. The risk of causing some type of a nerve damage is too high. Where's blood pressure? He's starting to ooze. Let's keep the pressure down. All right. Going to give a little numbing medicine, make him more comfortable. Shot. You guys can see the dilator going down along the guide wire into the foramen, and it's going past that very arthritic joint. Have we played the video yet on how the Duke laser disc repair actually works?
It's 111 systolic.
Thanks. Shot? Henry, I asked you a question.
I apologize. I was talking with Sanjay. Repeat that one more time.
Yeah, so have we played the video on how the DLDR works?
Not yet. No, no, no.
Let's do that. Shot? So we're inside the disc, and while we do this setup, putting the tube down, remember the whole surgery is done arthroscopically or endoscopically through this tube. It's called a full endoscopic Duke laser disc repair. Go ahead, Henry.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Hold on. All right, welcome back. As you can see, we placed the scope down into the disc, and what we're seeing here, right there, the blue stuff, that is herniated disc. We are just inside the annular tear, and you can see that nothing should be stained blue. There's a piece of herniation. Now this herniated stuff is stuck in the annular tear, and that's where all the pain comes from. That's why, folks, the 85 to 90% of chronic back pain comes from the annular tear in the back of the disc. That was discovered at Duke Spine Institute by me during my procedures. And the problem is that this tear that's painful in the back of the disc, there's no physical therapy that fixes it. There's no chiropractic machine or adjustments that fix it. There's no shots that fix it. There's only one thing in the world that fixes it, and that is the Duke laser disc repair. Now, there is another way to get rid of pain, and that is to fuse the joint. So we could do a fusion of these joints, and that would work as well, as long as the fusion is done properly, where you clean out the disc. A lot of surgeons don't clean the disc out because it's technically very difficult to do. So they just leave the bad disc there and they fuse from the back of the spine only. The proper fusion of a lumbar spine, if you're going to do it, is what's called a front-back fusion, where you go through the back, single incision, and you I remove the entire facet complex, because you can see the facets are abnormal. They're enlarged, and they're causing pinching of the nerve roots as well. So by removing the facet complex, you can restore alignment, and you can decompress completely the neuroforamen. By the way, this is part of the herniation. Look at all the scar tissue. The laser fiber is 1 millimeter wide, 1 millimeter. And Sanjay, you see the markings on the inside of the steel? Each of those are one hit. One hit by the laser, one pulse. And it's melted the steel. So the laser is very powerful. A lot of people don't understand that. They think the laser is, for some reason, not able to remove bone spurs or other tissue. But it removes bone spurs quite easily. As I was saying, though, with fusions, if you're going to do a fusion of the lumbar spine, you should always remove the entire facet complex for degenerative reasons. remove the facet complex so you get a good decompression. Otherwise, the patient will end up with radiculopathy that persists after the fusion. And you want to get rid of the radiculopathy, you got to fully decompress the foramen. They did a study and found, they found that the #1 reason for failed back surgery was residual stenosis, so the lateral recess and neuroforamen. And that's why there's a piece of herniation. That's why I always, when I do a fusion, I actually open up the foramen permanently with a Smith-Peterson osteotomy. And I described this in a paper I published years ago. You can look it up online in PubMed on transforaminal lumbar interbody fusion. But again, I've stopped doing them 99% of the time because patients don't want fusions. They want minimally invasive, endoscopic, fast recovery. All right, any questions from our audience?
Yes, we have a question from Lucas on YouTube.
Hi, Lucas, yes.
They ask, hello, sir. Do you have any opinions on orthopedic versus neurosurgeons performing spine surgery?
Hey, that's a great question. So to give you an answer, first of all, the most important thing in my opinion is it doesn't matter who does your surgery. What matters is how good they do the surgery. And when you weigh how good a surgeon does, you want to know the success at getting rid of your symptoms, and you want to know the chance of a complication, you know. So you want a surgeon who will give you symptom relief, but also an absence of complications. Now, had I, for example, at 5'1", had I kept going with that tube and just to do it for the sake of doing it, then I'm 99% sure he would have a complication. And that would be a L5 radiculopathy. And no surgery, you know, that's basically for pain on your back should create a complication like that. So we want to avoid complications at all costs. You want to avoid complications, okay? And the nice thing about these surgeries is they're controlled. And what controlled means is it's not an emergency surgery. He's not dying. And we have to move forward and do everything and take the complications as they come. We can actually mitigate the risk of complications by very careful planning and execution. And that's what I do. Okay, I don't put patients at risk for complications that are going to be lifelong complications. So when it comes to selecting a surgeon, whether it's an orthopedic or a neurosurgeon, what you really want to select based on is not whether they're an orthopedic or a neurosurgeon in general. You want to, for spine, you want to select on how good their results are, because that's really in the end all that matters. You want good results. And so I can't say that orthos are worse than neuros. That would be very prejudicial. And I know lots of neurosurgeons that are horrible surgeons, horrible spine surgeons. And I would never let them touch me at all, ever. And I know there's a couple of really good orthopedic spine surgeons out there. It really has to do with the individual, to be quite honest. And then the next thing that's important in my list is equipment and staffing, the team. Basically the team and the equipment available to do your surgery. So you can have a great surgeon who has horrible equipment and a horrible facility, and you're going to have a horrible result. I'm telling you, if you don't have the right equipment as a surgeon, you don't have the right staff, oh my gosh, your results can be so bad. That's why I left the hospital. I knew I was a great surgeon, I had great results, but the hospital was limiting my results. They wouldn't have an anesthesiologist anymore, they only had nurse anesthetists. I will not do major surgery with a nurse anesthetist, period. I'm sorry if I piss off every nurse in the world, it doesn't matter to me. It's the truth. We've become very complacent, allowing less trained, less qualified, licensed healthcare providers to do the work that more trained personnel should be doing. Let's face it, anesthesia is not hard to do 75% of the time. But that 25% of the time, when you have a problem and the patient's not making it easy for you, that's when you fall back on that training. And the whole idea of nurse anesthetists was, oh, they can go do all the easy parts, and when it gets hard, they'll call the doctor in. Well, that's morphed into, they never call the doctor in. And so, and that's because of ego issues, usually. Oh, I'm just as good. My training is just as good, right? So they are literally brainwashed themselves into believing they're just as good as a good, highly trained medical doctor anesthesiologist, which is not true. All right? They want the public to believe it too. So why would this shift happen? Well, it's happened for several reasons. Number one, there has been a shortage of anesthesiologists from time to time. And of course that has to do with reimbursement and how much they get paid, okay? And so Medicare kept cutting anesthesia reimbursement for years and years and years. And what had happened? Guess what happened? Medical students didn't want to go into anesthesia because they were getting paid garbage for all those years of hard work and sacrifice. They were getting paid a pittance. So they were not appreciated, okay? When you look around and you have, entertainers making 10 times your salary and you're living in an apartment because you can't afford, to buy a house as an anesthesiologist, that's wrong. That means society doesn't value you. So it's no surprise that doctors don't choose specialties that undervalue their hard work. So for years, the Medicare, the biggest payer in the country, kept cutting back anesthesia pay. And now they're paying $80 an hour for anesthesia, which is ridiculous. So what happens, no anesthesiologist will work for $80 an hour, okay? None. Dr. Berndes, would you, by any chance?
I call it the dilution of the practice, but it's being diluted. The skills and training are being diluted.
Yeah, the skills and training are being diluted.
Anesthesia assistants are further diluted. And what's doing is it's just trying to compensate for very low Medicare reimbursement,
Yeah.
which is setting the bar
Yeah.
for the private insurance reimbursement, which is ultimately destroying the value of
Yeah.
the practice.
Yeah.
The valuation of what you do, maintain normal vital signs, keep the patient safe and healthy in the perioperative
Yeah.
field.
So, all right, so that's like a book. I asked you a simple question. Would you work for $80 an hour for me? He said, hell no. So his reason, though, as to why anesthesia, there was a shortage of anesthesiologists. Basically, there's a shortage of anesthesiologists because medical students don't want to become anesthesiologists. All right, and that was how it was when I was graduating from USC in Los Angeles. Nobody wanted to go into anesthesia. By the way, there's the tear right there. You see the blue? That is the herniated nucleus stuck inside the annular tear. Remember you guys saw the video earlier, what causes back pain? That's it. So we're using the laser to debride that tear. So the problem is, as Dr. Berndes is saying, is that they're undervalued. So what happened was there was a shortage of doctors wanting to go train as anesthesiologists, which, all right, so the first thing you guys need to understand is when there's an effect, there's always a cause. It's called cause and effect. And the biggest mistake we make today is to assume that things happen that are not driven by some very powerful entity. And in this case, what's driving this is the insurance companies. They want less surgery, less anesthesiologists. So what they do is they control Medicare reimbursements, private insurance companies, okay? And they basically, it's kind of like if you're a developer in a city and there's an area you want to build high rises, you want to build office space. And there's all these people living there and you want to buy their house cheap and you want to knock it all down and build a big building, right? They won't sell to you because they don't want to sell their houses. You want to build a big building. They don't want to move. So what the developer does, and you've seen this in the movies, they hire thugs, street thugs, drug dealers, criminals to come in and start robbing houses, killing people, selling drugs to the kids. And guess what? Amazing thing happens. The homeowners move out. And then the developer can build their development. Now the developer, you know, you look at the developer and go, oh, they're not doing anything, because you don't know that the developer actually is behind this scheme. But they are. And in the end, the beneficiary financially of what's happening is the developer, because he's scaring everybody out and building his building. So the people that own homes, they would never be able to pinpoint the developer as the cause. So the developer is hiding, right? But they are the one driving this change, the crime, the violence. So what's happening in healthcare, the insurance companies are driving the changes. And how are they doing that? Well, they go to the board, they go to the medical boards, and they say, hey, we think nurses, all right, so first thing they do is they go to Medicare, which they control Medicare, and they say, let's start paying anesthesiologists less money. There'll be fewer anesthesiologists, and then everyone will be crying out loud, we need anesthesiologists, and then they'll let the nurses start doing anesthesia, because there's a shortage. So they decline the reimbursement, decrease the reimbursement from Medicare, and of course they follow suit. And they look like the good guys because, hey, we're just following Medicare. But they're actually the ones controlling the reimbursement in Washington, because Medicare is run by private insurance companies like Blue Cross, United Healthcare, and Cigna. So they're declining the reimbursement, and they are driving anesthesiologists out of medicine. And of course, everyone's complaining about it, and they're leading the complaint, and they're saying, we need nurses to do anesthesia. So of course they pressure politicians. They say to the politicians, hey, let nurses do anesthesia in your state, because there's a shortage of anesthesiologists. The hospitals will tell you. And the hospitals are powerful, so the hospitals complain to the politicians and say, yeah, we don't have enough anesthesiologists to do our surgeries. We need nurses. And the hospitals are salivating because, well, nurses are cheaper than anesthesiologists to hire and pay. So the hospitals are like, yeah, we're going to do just as much surgery as an MD anesthesiologist, but we're going to get away with paying these guys a lot less because they're nurses. And they'll take 60 cents on the dollar for payment. Of course, then the nurses get approved by the politicians to do anesthesia, and then they start at 60 cents on the dollar, and within a year they're at 70 cents on the dollar. Within another year they're at 80 cents on the dollar, and then pretty soon they're demanding equal pay to anesthesiologists, right? Meanwhile, the anesthesiologists are gone, and we've replaced them, high quality, intelligent, hardworking, dedicated, capable doctors with, you know, someone who goes and does a nursing degree for a few years and now can do anesthesia, okay? So, are nurse anesthetists okay? Well, they're okay if they're good, right? It comes back to the same question about what's better, orthopedic surgeon, neurosurgeon. Okay, what matters is the person. I've had some really good nurse anesthetists do my surgeries. I've let them. Like when I had sinus surgery, okay? My surgeon came to me and said, you can trust this nurse anesthetist. I said, okay, I trust you. If you trust them, I will let them do my anesthesia. Okay, so I put my life in their hands. Why? Because that's all that was available, and my surgeon trusted them. So when it comes to who's better, ortho or neuro, I would just as a generalization say that if you're having cervical spine surgery, I would trust a neuro more. And if you're having lumbar spine surgery, all bets are off. I think you just have to go with the best surgeon. But if you really want the best answer, you should come to Duke Spine Institute. You shouldn't be getting spine surgery anywhere else. That's the God's honest truth. All right, next question. This is all herniation, by the way. You can see it right there. It's all calcified. This has been around for a while. There's the tear right there. And the herniation is just pushing the tear open. So we're cleaning it out. And this is going to heal beautifully on its own without anything else being done. Okay?
Next question comes from Len Z on YouTube.
Sure.
They asked, looking back over the 16 years of DLDR, how has the body typically responded to the repair?
Yeah, looking back over the 16 years I've been doing this procedure, how has the patient's bodies responded to the tear? They heal every single time. Listen, I have never done a DLDR like this where it didn't work and get rid of the disc pain. Every single time it works. The only problem is, years ago, my patients, I didn't really know that, you know, going out and being active could put them at risk for reherniation. So I didn't give them really strict restrictions. And then we found that, oh, they were reherniating, right? So once I started developing some very strict restrictions, then they stopped reherniating. And those restrictions are no bending at the waist for 3 months to pick anything up from the ground, okay? And then, of course, you know, no contact sports like wrestling, jiu-jitsu, any kind of hard, rigorous sports. They need to take it easy. This is all the painful part of his disc, by the way. I've been cleaning out his herniation. You see, this is not normal tissue. None of it has been. All the stuff I'm removing is herniation and inflammatory tissue and calcium. You see all the calcium, the gold stuff? So people wonder, hey, are you taking his disc out? No, we're not taking his disc out. We're leaving the disc alone. As a matter of fact, that's the whole reason why we can do the surgery, is because we're leaving the disc there. Thank you. When you take the disc out, you have to put something back there, like an artificial disc or a piece of metal. So in his case and everybody else's, we don't remove the disc. We remove the herniation and we clean the tear. You know, the old technologies, the old-fashioned surgery, surgeons would remove the disc. It was called a discectomy. Unfortunately, a lot of surgeons still do discectomy because they don't know any better. But in reality, discectomy is a horrible surgery. In my opinion, it shouldn't be done anymore. And surgeons need to catch up and learn the latest minimally invasive techniques. Honestly, fusions shouldn't be done anymore for degenerative disc disease. You know, this procedure works very well when combined with the Duke plasma rhizotomy for facet pain. Then you're treating all the pain sources, which is disc and facet. Now, I'm going to be honest, there's a piece of herniation. It's a good size. Oh, there it is. There's the main herniation. We got it. Turn on the light. Bring me something, a blue towel or something. You guys see this, Henry?
Yes, we do.
Come on, we don't have a lot of time. You guys see this thing? It's huge. Let's bring the tape measure. That was the main herniation, all right? It took me a while to find it, but we got it. Not everybody has a giant, look at that thing. I mean, this is amazing. It looks like a dragon. This has been biting his back for years. Look at the vascularity here. Those are like ingrowth of blood vessels and stuff. Okay, that is huge. This is a really good one. I think he's going to enjoy seeing that thing. That is 2.5 centimeters. Looks like a dragon. All right, cool. That should be about it. I think we're almost done here with this disc. So there's the herniation and then there's the annular tear. We got the main herniation out now and things are looking good. I'm going to clean the tear a little bit more and then we'll be done here. We're going to move on to the next disc. Huh? Did his blood pressure go down after we took that out? That'd be kind of cool to see. It did go down? No way. So Dr. Berndes is saying, and he's the first one to notice this, by the way. I never knew this all these years, but when we take those kind of herniations out, the blood pressure of the patient goes down. By the way, I don't know if you guys know this, but pain increases your blood pressure. So these patients that have chronic back pain for years, their blood pressure goes up. So this surgery is able to decrease their blood pressure if their blood pressure was up from pain, which is a very common reason to have your blood pressure go up, chronic pain.
It also affects serotonin in the brain, causing depression.
What affects serotonin?
Pain, chronic pain.
Chronic pain affects serotonin. Dr. Berndes is reminding us. All right, this all looks good. I'm just about done here, 30 seconds. I'm going to move on to the next disc and then the DPR. See guys, avoid open surgery. The nerve is right up there in the fat. I do want to zap this little bit of herniation left. It's not really much, but it's good just to get it. So anyway, getting back to what we were talking about, patients don't come back with disc pain. They come back, if anything, with other areas that cause pain, like the SI joints, the piriformis, other things.
Lights off, please.
And we always have to figure it out, you know, what is bothering them. And it's not reherniation. As long as they follow our instructions, it's not reherniation. It is not the disc that we operated on. It is, scope off, it's always going to end up being something else. So it's just a matter of figuring it out in each person's case. But, you know, I could say to you everybody's different, but in reality, they're all different, but almost the same, because the pain source is always going to be those 30 things that cause back pain. And it's just a matter of figuring out what each person's combination is, you know. Is it the L4-5 disc and the facet? Is it the L4-5 disc and the SI joint? Is it the piriformis, the SI, and the facet? So everybody's different, but the actual source is the same. So it's really easy now for us to figure it out, what's causing people's back pain. The reason other doctors don't figure it out is they don't know what causes back pain because they've never studied it. We had to learn all this on the job, so to speak.
Or you have to care enough to figure it out.
You got to care enough to figure it out, but you got to believe you can figure it out. A lot of doctors are taught you can't figure out what causes back pain. Nobody knows. It's non-specific. People just have to live with it. They're basically brainwashed to believe that. But, you know, I'm not the first person to think the disc is the cause of the pain. You know, that goes back 100 years to Cloward. Cloward even thought the disc was the cause of the pain. And he did some experiments. But for some reason, I think I know why, too. I think all this knowledge has been suppressed by the insurance companies, to be quite honest with you. They have suppressed this knowledge through the system. They've promoted the idea that back pain is something you're just going to have to live with, that it's not fixable. Because the only way to fix it is surgery, and surgery costs them money. They don't want to spend the money. They'd rather people live in pain, because it's cheap to pay for pain pills. You know what I mean? If you're an insurance company and you have to choose surgery, $100,000, or pain pills, you know, $10 a month, and the patient, guess what the patient's going to do? After a year, they change insurances. So Blue Cross is like, hey, in a year you'll be gone, and all I did was pay $10 a month for your narcotics, right? So they're, huh?
The actuaries track all the spending.
Yeah. Hey, you know, I mean, this kind of shit happens. Like GM, right? GM bought the rights to electronic vehicles, electronic cars, like 80 years ago or something like that, right? And they buried it in a safe so nobody would ever create an electronic vehicle because they want to keep the gas guzzling vehicles, combustion engines. Think about it. They would lose a lot of business, right? So these very powerful corporations basically suppress new technology that's going to affect their business.
Well, they're comfortable if they know how to build combustible engines. They're not that sure about that. Electric,
Yeah, but they may also own gas refineries. Why would you want to promote an electric engine when you own Exxon, you know? You're making money on both sides. You're making it on the cars, and you're making it on the maintenance, and you're making it on the fuel and lubricants, right? No, this is what's happening. The insurance companies have suppressed the knowledge of fixing people's back pain with surgery. And they probably have known for years that surgery is needed. And they keep fighting it, and they keep making it harder for people to get surgery. I look at the Blue Cross and the Cigna and the United, what's called medical necessity for spine surgery. And as fusions have grown in the United States over the last 20 years, which they have, they've gone from like 400,000 a year back in 2004 up to now over 2.5 million fusions a year on spines. Yeah. So they've seen this growth, and even more that are recommended that don't get it. They're seeing this, huh? That's United States. They're seeing this growth in you know, expensive spine surgery, and they're now creating policies to restrict it and limit it. Yeah.
You would think they would love our procedure.
Huh?
Love our procedure.
They would, the insurance companies would love no procedures. Okay? They just want to take $1,200 from me every month and give you zero, because that's how they make the most profit, right? Like if you take the money, $1,200 a month, and you give zero, then you've kept $1,200 a month. That's profit. I mean, you have to pay some measly administrative fees,
Scoball, please.
but you know, to your staff that just deny things. But in the end, insurance companies are for profits. Okay, even if they're called nonprofit, they're still for profit. Like they have ways of profiting, trust me. Blue Cross Blue Shield, do you think that they're charity? Hell no. Somebody's making billions of dollars a year in profits.
And their CEOs, they're at the top.
CEOs aren't even the problem. CEOs make a few million. They siphon off billions of dollars in profits. But they hide it from the public. The reason is simple. They don't want the public to know how much money they're making. Can you lower the IV pole? If the public knew they were making $1 billion a year in profits, or $2 billion or $10 billion, United Healthcare makes $20 billion. Yeah. If they knew that they were getting their cancer treatment denied, saying it's not necessary, but United Healthcare is making $21 billion a year in profit, which they are, they would be furious. If they knew that the reason the denial for cancer treatment was financial, the public would be a lynch mob that would be coming after UHC. But UHC and the other insurances have somehow managed to brainwash our public, like literally Matrix style, into believing that they're taking care of their best interests. Oh, we denied your cancer treatment because it doesn't work. You know? But I know the truth. I think most people understand the truth, but they don't know how to hold the system accountable or make change. So they need guidance. They need leadership. We need leaders to basically go out and fix this problem, the insurance companies, because it's getting worse. All right, what other questions do we have?
We have a question from Gary on YouTube. And they asked, is that blue dye, or is that the color of the inside of the disc?
Yeah, Gary, that is blue dye. We inject it during the discogram, and it's the Duke Spine Blue. And basically, it stains to only one thing and one thing only. It will not stain to bone. It will not stain to scar tissue. It will not stain to calcium. It will not stain to a normal nucleus pulposus. It will not stain to the annulus. It only stains to degenerated nucleus pulposus. And the only way to get degenerated nucleus pulposus is with a herniation. There's no other way. So basically it stains the herniation. So we want to get rid of as much of this degenerated nucleus as we can with the laser. And that's what we're doing. It's called a vital dye, vital dye. You can see the tear with it. It also helps me see the tear. You guys see that tear? These are all pieces of herniation, by the way. And I can tell you, these are all like mostly kind of scarred up pieces of herniation. Not a nice big one like we saw on the last disc, but maybe there's something hiding in here that we'll find. And you can see how the pieces of herniation, they're released by the laser. They float up to the top and out of the patient. But you're right. Somebody asked a question and they said, Dr. Duke, if this surgery was covered by the insurance, wouldn't it be better for everybody, including the insurance? The answer is yes. And the surgery is covered by a lot of insurances, it's just not covered by all. Then again, I don't know any insurance company that covers everything. So, but it should be covered by every single insurance company. And I'm going to tell you why. First of all, if this surgery was covered by the insurance companies 100% universally everywhere, then people would never need pain management anymore. They would literally be gone. So all those drugs that people take, all the marijuana, all the opioids for pain, for their spine, gone. Pain management, epidural steroid injections, facet MBB, RFA, gone, 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 no more. Literally, the insurance companies would say billions of dollars. Billions, tens of billions every year. Complications from spine surgery, like fusions and artificial discs and laminectomies, discectomies, complications gone. So they wouldn't have to pay for complications, which happen often in more invasive surgeries. All that complications payments gone. Just to give you an idea of a typical spine complication, the average spine complication costs around $200,000. And some of them can cost millions of dollars. Like if you're having a spine fusion and you get an infection after your fusion, you're going to be admitted, you're going to be operated on again, you're going to get debrided, you're going to be put in the ICU, you can go into renal failure, pulmonary failure, multi-organ system failure, and you can almost die, and you can run up a bill of easily $1 million, $1.5 million in the hospitals, okay? That's never happened with Duke laser disc repair, ever. In 16 years, it doesn't happen. I mean, as long as it's done properly, of course. There's lots of ways to do it wrong. So complications from spine surgery, gone. Expensive fusion surgeries that cost them billions of dollars a year, gone. The average fusion surgery cost the insurance companies $100,000. Okay, that's cervical and lumbar. There's 2.5 million done a year, so do the math. How many is that? 2.5 million times 100,000. That's just without complications. What's the math, Henry?
Doing it right now.
By the way, these discs are a lot worse in person here than they looked on the MRI. On the MRI, I knew there was a problem because I saw the tears, but look at all this devastation. It's like a grenade went off in here. Huh?
It says it's a number that it's too hard to count.
Too hard to count. Henry, aren't you Jewish?
You are. That is a fair point.
How could there be a number too high for a Jew to count? Come on.
It was like it's like 2.5 E11.
Yeah, 2.5 to E11. What is that? 250 billion?
It's got to
Or
be
25 billion? I
was-
don't even know.
I was gonna go for trillion.
All right, let's just say 25 billion to be conservative, because we're stupid over here. We're not financial people. I don't even know. But it's, you know, they're saving 25 or 250 billion, whichever one it is, on fusions, not paying that money every year. Okay?
It's billion, 250 billion.
250 billion. There we go. Then on top of that, so you got complications, you got the actual surgeries, 250 billion. Complications, I'm sure around 25 billion, 10% of that. And then you got the pain management procedures, all the epidurals, facet blocks, oh my God. Billions of dollars, tens of billions a year. Then, on top of that, no more spinal cord stimulators. Like they're putting those things in left and right like it's water, candy. Okay, stimulators are costing $50,000 a stimulator. And there's hundreds of thousands being done a year for back pain, neck pain, thoracic pain. And they don't work. They just don't work. But they are the best things we have other than open surgery. And they suck. Meanwhile, this surgery works every single time. We have never had it not work for 16 years. Okay? So, and this surgery is dead cheap compared to all those other treatments, less than a spinal cord stimulator. So yes, we could save the insurance companies hundreds upon hundreds of billions a year worldwide, with this procedure. So someday they're going to understand that. And when they do, I think they'll probably either embrace it or they'll be forced to embrace it. So, great questions. Here's another piece of herniation. You guys see how the laser works. It just basically frees up all these pieces of herniation from the scar tissue holding them to the wall of the disc, called the annulus fibrosus. Okay? So, now these pieces will not come out on their own. I've tried. You can't grab them out with a grabber. They don't come. They're too sticky. They're too stuck down. You have to literally cut them out. And that's what the laser does. Remember, the inside of this tube is only 5.5 millimeters. 5.5 millimeters. It's tiny. Any questions? Look at the red stuff here. This is where the pain comes from. The inflammation, that's what's red. All this is inflamed. This is why he has so much pain. If you remember when I tested him about 30 minutes ago, this disc right here was more painful than the one we already did. And you can see all the redness there. I just zapped it. That's all inflammation. That's why it's hurting him so much, inflammation. And the reason why he has inflammation is this stuff right here, the herniation, the blue stuff, stuck to the wall. Okay? Again, discovered at Duke Spine Institute 16 years ago, published multiple times in the medical literature. Questions?
No current questions, but we do have a comment from Ratan on YouTube, and they said they are watching this video from Bangladesh.
All right, Bangladesh. Very nice. And this patient is actually traveling from Oklahoma. Later on today, we have a patient from Africa, from Rwanda. He doesn't want to be broadcasted, though, so you guys may not see his surgery. And of course, we always ask our patients first, do they allow us to broadcast or not? And of course, you don't know who this person is. We're not going to tell you, but a lot of people don't want to be broadcasted. They would rather not broadcast their surgery, in which case we honor their requests for privacy. Looks like a big piece of herniation here. I got about 5 minutes on this one, maybe. And then we're going to move on to the facets because we've already done the SI. Man. A lot of scar tissue there, just at the back of the disc. He's definitely not making it easy for me. Come on. Any more questions?
No current questions.
Let's run the video one more time on how it is that a herniated disc can cause so much pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, you've seen now how, once again, how a herniated disc does cause back pain. As a matter of fact, herniated discs are the most common cause of back pain. They account for about 85 to 90% of chronic back pain. The rest of the back pain comes from the facet joints, the sacroiliac joints, and the piriformis muscles. Of course, there's also fractures that happen, but fractures are easy to diagnose. If you have a fracture, you'll see it on the diagnostic imaging pretty easily. The problem is that most people don't have fractures. Fractures are very rare. And of course, tumors and infections are easy to see, but thank God they're rare too. Really, the most common cause of back pain is degenerative. And degenerative conditions are fixable, okay? We're basically talking about arthritis, inflammation in the joint, that you just have to find the source, which we do at Duke Spine. We target the source. This is the end of the disc right here. Like, we're literally just almost outside. I'm just cleaning the last few pieces of herniated nucleus, and then we'll be done here. This is all scar tissue with herniated nucleus attached to it, meaning that the cause of the scar tissue, of course, is inflammation, and the inflammation is, of course, caused by the herniation, okay? So, can't really see inflammation, it's microscopic, but when you get a lot of it in one area, you can actually see redness. You can see redness and injection of the vessels in the area. Like a lot of these little tissues here, they're kind of pinkish red from inflammation. So, in summary, his discs were a lot more damaged than the MRI led us to believe. How much energy have we given so far on these discs? 40? 45? 35. 35 joules. Joules or watts? I always get them. Joules? Yes, sir. So this disc has taken a lot. Let's try to grab any of that out.
Just jumped up to 36.
So, yeah. Our average per disc is probably around 25. Wouldn't you say, Jordan?
The average disc the last one was about 47.
Yeah, these two, oh, laser on. These two have been really, laser on. These two have been unusual though. Not, you know, compared to our normal. All right, that little bit of vein, bleeding there is vein. That's expected, and it's a good sign. It means systolic has come down, huh? So how much would you say his blood pressure has improved now that we've gotten the herniations out?
20
Huh?
20 points on the systolic.
20.
20 millimeters of mercury.
Yeah, 20. Let me just look, Luis. Looks good. I'm going to clean that up a little bit more. People ask me about the hole here, and the hole we leave is about 3 millimeters when we're done, plus or minus. This is the hole right here. We're just cleaning it up. It's a little bit more scar tissue there, a little more herniation. But overall, I feel really good. I think he's going to do very well. Not happy about the 5-1, but you know what? I can't fix something that can't be fixed. So, looks good.
Lights on, please. Lights on.
All right, any questions?
Yes, we have a question from Andrew on YouTube. They asked, does the herniation ever occur out of the repaired tear during the during the healing time?
Yeah, great question. So we get that question a lot. Can the disc re-herniate during the healing time? The answer is yes, but it takes a lot of pressure on the disc an unusual amount of pressure, not with normal activities. You would have to be jumping, you know, up and down on a trampoline, loading your spine. You'd have to be doing some kind of high intensity workout or sports. But it doesn't just with walking around and doing normal activities, going to work, it will not re-herniate on its own. Everybody thinks the disc jelly is like liquid, but it's not liquid. It's like it took me years to figure it out, but I think the thing that everyone can relate to that is most like the consistency of a disc, the nuclear material, is a shrimp that's uncooked, or crab that's uncooked. If you've ever eaten shrimp or crab and you had to cook it, you know that like before you cook it, it's very watery kind of and bouncy and squishy, but you know, that's what the nucleus is like. So it takes pressure to squeeze it out through that hole. It takes a considerable amount. So as long as the patients refrain from any kind of, you know, serious activities like wrestling or whatever. I mean, the list is super long. I can't go through everything, but as long as they just do normal walking around, shopping, eating, going to restaurants, working, they're not going to re-herniate. And that's proven by my results. If they re-herniated all the time, they'd be coming back and having another herniated disc surgery. How often, if you go back and watch the last 500, how often do you see me doing a redo herniation? You never do. Why? Because it doesn't happen. It just doesn't happen. All right, shot. All right, so I'm going to aim for, let's see, there's 5-1. So I'm going for 4. Shot? What do you think this is? Huh? A num-num house? Shot? You're always wanting num-num. Always. Shot? Shot? So I'm trying to, I can't really see the target that well because the discogram has actually painted the nerves there. There we go. Shot. All right, that's really good. I'm right on the TP. Shot. I'm right where we want to be. I'm just trying to get a little more north. I'm just inching my way. I mean, that's really good right there. Shot. Show the nerve there. Show the nerve, the L3, L4 nerve root. Right there. You see that? The dye is outlining it. The nerve is actually in between. All right, so I'm going to give a little numbing medicine to make Dr. Berndes happy and the patient happy. Now this part of the surgery is called the Duke plasma rhizotomy, and basically the idea here is to deaden the pain nerve to the facet joints that are painful. Now we're not the first in the world to do deaden the nerve to the facet joints. That was discovered years ago by, you know, people much smarter than me. Shot. But we're the first to do a new technology where the problem with the procedure has always been, shot, that it doesn't last. It doesn't last. Doctors do it, and then shot patients come back, and the patients are having pain, and then they got to repeat it and do it again, and so nobody wants that. Shot. And as a matter of fact, you might have to repeat it, you know, 20 times in some patients, right? Because after all, it's just temporary. So we figured out, well, I mean, clearly the technology works. So what's the problem here? And the problem is, it doesn't last. So why doesn't it last? That's what I asked. Why doesn't it last? And that's when it became abundantly apparent it doesn't last because they're not doing a good enough job of killing the nerve. And then I started to think back on all my surgeries over the years and how, man, we're actually working right in this area all the time. Shot, you know, with fusions. And I started thinking about it, and I realized, you know, shot, I do this procedure every time I do surgery. And I never have people coming back complaining about pain. So,
and then 2x4 long ones.
that's when I realized I was doing this already, all those years, but never by itself. Never a standalone procedure. So, I decided, hey, you know what? Let's try this. And what do you know?
Yeah, thank you very much.
We were able to cure people's pain permanently. We haven't had a single person come back that it didn't work. All right. And we've been doing it for over a year now. Does that look good to you, Jordan? It looks good to me. The TP on the other side is like right there, right? Yeah, I agree. And I'm right on the TP. Shot? I feel the TP. I just want to get a little more medial. Can you see the pedicle there? So we took this thing that I had already been doing for years and just made it its own procedure, basically. And my God, we have had some incredibly good results. So good that we said, shit, let's do this for knees and shoulders too, right? Shot? So we started doing it for knees and shoulders and hips. Oh, and the results, incredible. We'll do one more, just to be sure. You know, you never know with that Patel guy. Right, Luis? Shot. Just kidding. Dr. Patel's wonderful. So the last target, show us the target, Jordan. Shot. Yeah, I'm too far south. Shot. Shot. She hot? And shot. Two inferior and two medial. Shot. Two medial.
That's perfect, yeah.
Shot. Two inferior. Shot. Just getting there is challenging sometimes, especially with a lot of arthritis, like some of these patients they have. Like this patient, for example. Shot. It's funny, the contour wants to take me to the same place Patel went. Shot.
Yes.
I was talking earlier that he has some type of a segmentation abnormality here, meaning that his bones did not form normally when he was in utero. Shot? Oh yeah, that's nice, huh? You like that? Jordan? I agree. Yeah, that should do it. Great job, everyone. All done, right?
Yes, sir. Yeah.
Type your questions up. I'm happy to answer them for you face to face, but this surgery's done. We've done a left SI joint DPR, a left 4-5-5-1 facet DPR. We did the DLDR left 3-4-4-5. I couldn't gain access to 5-1. It's because of the anatomy, and it wasn't safe to proceed, so we had to abort 5-1. But I think he's going to have about 95% pain relief, if not more, permanently. So we're very happy about that. All right. I'll talk to you in a few minutes. Type up your questions. Great job, everybody. I need to sign off here. I need a pen. Always make sure there's a pen here. And then make sure this is not underneath. Why? Because when I write here, it's going to write it here. So, no, let's get it right. I do everything exactly the same way every time. So just study what I do and comply. Good morning, I'm Dr. Duke Majan at the Duke Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Duke laser disc repair. We performed that 12 hours ago, and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics, killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day, and I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life.
Absolutely.
Worth the trip. Pain robs us of our dignity, doesn't it?
It does. It absolutely does.
And your parents are here, and they're very supportive. And that, to me, is so important, that you have people that understand what you're going through. I'm sure your parents have been a big support for you.
Oh, absolutely. Yeah, I was at work, a short story. I was at work last Wednesday dealing with this pain, and my back finally gave out to where I literally could not walk anymore. And I was 600 miles from home. And so I called my mother and father. They flew to San Diego and arranged the trip to get here. I called your place. I was scheduled for February 2nd, and I asked Richard on the phone if he could get me in sooner, because I was desperate. And you guys got me in a week or two sooner, got me in the 24th, which was yesterday. And so we made the arrangements, and I flew here, stayed in the hotel for a couple days, and was operated on yesterday. And yeah, it's well worth the trip. I apologize for getting emotional, but it's been a long trip to get here.
Well, we want you to get emotional, because it is an emotional thing. When you've been burdened with this pain for so long, and then suddenly it's gone, and you realize that life can be lived without that pain, you know, and that you can actually have a life without the pain.
Yeah.
So what are you going to do now that you don't have the back pain anymore?
Well, I'm going to get my life back together. I've got a new job, and they've saved it for me. My boss is wonderful, and I'm going to go back to work tomorrow, actually, if you can believe that.
Yeah.
And I'm going to start riding my bicycle again and getting healthy again.
Well, your surgery went very well. I don't know if you've watched it yet, but we were able to get in with a tiny 7mm 1/4" incision and fix both painful discs, and they were both very painful for you. And the pain was coming from a small tear that's located in the back of your disc where your herniation came out of. And that tear was just so inflamed, and we were able to clean out the herniation that was stuck in your tear and use the laser to debride it. And that's what the Duke laser disc repair is. It's a debridement of the annular tear to eliminate back pain and leg symptoms. So we also have a cyst. We didn't treat your cyst. And do you think the cyst is causing any problems for you?
At this point, no. I don't think so, because all of my symptoms are gone. This morning when I woke up, I was a little nervous about getting out of bed. But that subsided quickly when I stood up and could stand up completely erect. with no pain or bindage feeling in my back.
Yes, when I walked in and saw him this morning for the first time, the first thing your mother said was, "Look how straight he's standing." So they must have watched you suffer for a long time.
Oh yeah, yeah, yeah. My mom's a great lady. I'm blessed to have her in my life, and then that's my stepfather, Jerry. He's a wonderful man. He and I are pilots. We fly together. We do a lot of things, and he's seen me go downhill. He knew something was wrong, you know.
How did you find out about us?
I've been seeing a chiropractor in Sacramento for 35 years, and 2 months ago, I started to really feel bad, and I would go to him, and after about a month of going to him and going to my doctor for some pain management for these symptoms, I finally figured out that something else was wrong with me. And so I asked the chiropractor, what can we do, because what you're doing is not helping me. My doctor put me on pain meds, and they took some of the sharp pain away, but nothing was helping. And so being kind of a mechanical engineer, I decided to look into how my back was put together. And I requested an MRI from my doctor and from my chiropractor. And so that took 3 weeks to schedule. That's a long story. And I finally got an MRI, and I looked at it myself and realized that I had a cyst of some sort and that I had some problems with my lower discs. And that's when my chiropractor told me about you. He said, get on the internet and do some research and then call these people. So I called your store. They gave me some information. I FedExed my package to you guys, and a week later you called me. And about a week or 2 later, I got here.
Wonderful.
So, yeah.
And here you are pain-free for the first time in many years.
Many years, many years.
Congratulations.
Yeah. Thank you.
Is there anything you want to say to your fans out there?
There is. This is a miracle. In Sacramento, everybody that I know said, why are you going? Why are you going to Florida? Why don't you find somebody in Sacramento? And I said, well, because I was referred to Dr. Duke Majan, and I've done a bunch of research on him, and I just have a great feeling about him. Not only that, he personally called me on the telephone because I told his people that I had some questions, and that's what sealed the deal. And so it took a while to get here, but it was worth everything. And I would recommend anybody send your MRI to this guy, and if he can help you, he will. Okay? Thank you, Doc.
You're welcome, sir. It's my pleasure.
Yeah, absolutely.
All right, go enjoy the rest of your
All right,
life.
thank you.
Good morning. It's February 22nd, 2023. I'm Dr. Duke Majan. I'm here with one of my patients who traveled to Duke Spine Institute, not too far away from Jacksonville.
That's correct.
Yep.
That's where we're from.
You found out about Duke Spine through the internet.
Yes, I did.
And why did you end up coming here?
I ended up coming here because I could not get rid of the pain that I had in my back and in my leg. I tried to exercise. I tried every physical therapy, yoga, everything you could think of, and I just could not get out of it. It just would linger and linger and linger, and it wouldn't go away.
How long have you had that back pain for?
This back pain has lasted me for the last 6 years. It started when I was working at the garden stores, doing a lot of heavy lifting. I took some time off from it, and then I jumped back into work, and the pain, just when COVID hit, I just had gotten a job in the garden, took another job in the garden store, and shot down my leg, and it's been like that. The pain's been like that for 2 years. So, you know, now it's 2023, and came here to see you, and yesterday we had it done, and in 1 day I'm doing a lot better now.
So you had the Duke laser disc repair done yesterday at L4-5, L5-S1. You could see us in there with a tiny 7mm incision, the endoscope and the laser, cleaning out your disc. And clearly, to me, the disc did look injured, like they were about 5 to 10 years of injury. So it's been going on for a while for you. And you have degenerative disc disease. So a lot of people ask me, does the laser surgery work to get rid of back pain and leg pain when it's degenerative disc disease? What would you say? sitting here
It's-
now.
Yeah, I mean, my worry was that, the disc had gotten just so bad that it wasn't really replaceable, that, I was recommending a fusion. And I certainly did not want that. When the pain came on, I researched and found you and said, no, I don't have to do that.
That's
I don't
right.
want to have to do that. That's just not right.
Yeah, so you have degenerative disc disease at L4-5, L5-S1, but you had back pain coming from them. We did the laser surgery, we didn't do fusion. Is your back pain still there?
No, it's
Gone.
gone. It's gone.
Yeah. And the pain in your right leg, down the back of your right leg, is that still there?
That's gone.
Gone. Now, is it gone because we put you on narcotic painkillers and you're loaded up on morphine right now?
Yep. No pain medicine, no anything.
So what did you take after the surgery? You took a Tylenol,
Tylenol,
Robaxin,
Robaxin.
and are you still
fact-
taking them or are you eating them?
I took them this morning, in fact, so I didn't even take them right after. Went to dinner after this, and yesterday went to the hotel, slept real well, and got back up, and
So no
things are looking
narcotics. You've been up
And-
walking around.
Yeah,
The surgery was
and
outpatient.
At 62, this is my time to really concentrate on my health and get back to the exercises and the walking I want to do, the swimming I want to do, the bicycle I want to do, the living, not the existing.
Exactly. Living because
Not
you're
ex-
not limited by
just
pain
more.
anymore.
Yeah, and maybe I was a judge was good. We did disability over the phone because of COVID, and he awarded me that,
Congratulations.
and that was 2 years ago. But I don't want to depend upon the government. I want to go out and get working again.
You
So
may not need disability anymore. What do you think?
that's where I'm going.
I want to mention one more thing.
Sure.
You did have surgery already before you came to me.
And that's another thing.
You had laminectomy.
Yeah.
Did it work for you?
I have to say, it may have worked only because my first surgery, and I stopped the work that I was doing at the Jacksonville Zoo and Gardens. I'm a horticulturist, so.
But if it worked,
But it
you wouldn't be
be
here having
here
another surgery.
No.
So did it
Because-
work for you? Did it take away your back pain?
No, it didn't. Not in the long run.
Did it
No,
take
because it
away your
weakened the
leg
spine.
pain down your leg?
No.
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 So the problem with laminectomy is people feel good maybe for a little while, a few
That's
months,
right.
maybe a year, but then because they've removed all the bones and ligaments
That's exactly-
from your spine, it causes things to get worse. And
That's
they're
what-
not addressing the disc. The disc is actually the cause of all the pain.
Right.
And they didn't fix your disc.
No, because when I had that surgery, I stopped the job I was doing, took time off, and went back to and boom, it went back in.
Okay, so as soon as you got active again, the pain came back.
That's right.
Yeah, that's the problem, is that you really just limited your activities rather than fixing the source of the pain. Laminectomy doesn't do that, doesn't fix the source of the pain. The Duke laser disc repair does. Well, congratulations. I'm
Great.
happy for you.
Great.
And I'm excited for you and the rest of
Sure.
your life. 62, you're going to start enjoying life and doing all the things you want to do. But remember to
Absolutely.
let it heal first, okay?
Yeah, we're gonna let it heal. And before I put that big heavy guitar on me, because I am a guitarist,
Of course, there you go.
So-
Anything you want to say to your musical fans out there?
just remember, keep on rocking in the free world. If you need some help, come to this man. He is amazing.
Yeah, we got a Leonard Skinner fan, right?
Yeah, I love the Southern rock.
All right, thank you. And this is Dr. Duke Majan. I hope you enjoyed that testimonial as much as I did. That's what we do here at Duke Spine Institute. We figure out where the pain is coming from exactly, and we go in and repair that area. It turns out most of back pain comes from disc injuries, like herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, prolapsed disc, slipped disc. They're all the same thing. You know, we try to make the disc seem so complicated, but the disc is so simple. It's actually probably the simplest structure in the human body, if there is such a thing. The disc has two parts. It has a wall that circles around a hydraulic center that's soft. And that hydraulic center that's soft is called the nucleus pulposus. Now the nucleus pulposus is mostly made up of hyaluronic acid and chemicals or molecules that absorb water. So it's very, very watery kind of thing. It's not watery like you think about running water, but it's full of water. And I like to use a uncooked shrimp or uncooked crab meat. And now people are going to get angry with me because they're going to go and have shrimp scampi, and all they're going to think about is their disc. But if you take a piece of uncooked shrimp and you look at it, it's rubbery, you can compress it, it's compressible, but if you press too hard, you can crush it, and the meat will separate and a chunk will come off. And that's exactly what happens with the nucleus pulposus. When you injure your disc, you injure it through the bones making a sudden compressive force and rotational or extension, and you're crushing the nuclear material, the shrimp, and you're tearing the wall right behind it. And so what happens then is, you get this tear during the initial trauma, and then over time, over years, you're lifting, bending, playing sports, and you're constantly, your bones are squeezing down on each other with all that weight of your body, and it's pushing those little pieces that you crushed out through the tear. And maybe you do some more crushing as well. So those little pieces are called herniations. And everyone says a herniated disc like it's one thing. It's not one thing. It's around 20 or 30 pieces of herniation that have sequestered in that area over the years. So a disc has two parts, the annulus and then the nucleus. So why so many names? Prolapse disc, bulging disc, ruptured disc, herniated disc, extruded disc, slip disc. They're all the same thing. They're a tear with a piece of herniation or two or three or more coming through the tear. That's it. And then over time, the disc will degenerate and collapse as it dries out and gets desiccated. Okay? So the problem is that many countries, many doctors, many languages, perhaps many misunderstandings has led to many names for the same thing. In the end, it's quite simple. It just takes a laser, a scope, and being in the right place to fix it. And that's what we just did for this gentleman's 2 discs. Now, I couldn't get to the third one. I tried and tried and tried, and it turns out that if I can get a model of a lumbar spine, it turns out that he has several problems. Okay, forget about the screws and rods. They're not important. But let me get my pointer. My pointers seem to disappear. Oh, I see them over there. All right. So for those of you who've never seen the surgery before, the problem this patient had was multifold. The reason I couldn't get into the L5-S1, he has a high iliac crest, not a big problem. I've gotten through that many times. But when I came down to the facet joint, this facet joint was completely abnormal. It was growing bone spurs all around it, and those bone spurs were growing in this direction towards the disc. So as I came down, trying to go through the frame and to get to the disc like that, this is normal, okay? You can see that. That's a posterolateral approach, transforaminal 5-1. I couldn't, I kept getting pushed upwards this way towards his nerve root. So every time I tried to make a pass, this facet joint, being so bony and arthritic and abnormal, was pushing me up towards the nerve. So every time I got close, I was too close to the nerve root. There wasn't enough space and the anatomy wasn't right. So what would happen if the 1 millimeter needle was bothering his nerve root, it was irritating it, the 7 millimeter tube is going to be 7 times worse. And I don't want him having problems with the nerve root. So I made a decision, and this is something most doctors have struggled with, is there's a saying we have, it's called first do no harm as surgeons, meaning we don't want to do a treatment where the complication is far worse than the benefit of the treatment. Now, I was able to treat everything else we set out to treat. So that's, everything else is at least 95% of his back pain. That one bottom disc I couldn't get to, and I may have to try to come from the other side in the future. If it's still bothering him, we'll talk about it. But I never do anything I don't discuss with the patient first and get their prior authorization approval for it. Okay? So let's go to our questions.
First question comes from Len Z, once more on YouTube. And they asked, if the redness is bleeding, seems logical the body is trying to heal itself. Why can't it? Are we not giving enough time to heal? Are we not staying immobile long enough?
Great question. All right, so he's saying if the redness is bleeding, it's not bleeding. The redness is blood vessels. that's blood within capillaries. So bleeding is the act of blood leaving the blood vessels, and the blood is not leaving the blood vessels, it's just filling the blood vessels, and there's more blood vessels in that area. So if you look at something that's inflamed, your body will actually over time recruit more blood vessels to that area, so you get more circulation. And the reason for that is, after all, it's fighting a war. That's what inflammation is, and the longer it fights the war, the more resources it needs. So you start to build new highways and pathways for the troops, the inflammatory troops, to get to the area of inflammation. But you are correct, there's a foreign body there, at least what the body considers to be a foreign body, or at least what the inflammatory system considers to be a foreign invader, and it's attacking that invader. That invader is the herniation. So why can't the inflammation destroy the herniation and clean it out? That's what it's trying to do. It's just there's too much of it, and that herniation is extremely pro-inflammatory, meaning it stimulates inflammation. There are things that really are biologically inert. They don't stimulate a response, either immunological or inflammatory, and there are things that are highly inflammatory. And this is something that's highly inflammatory. Those studies have been done, and it's been shown that nucleus pulposus is highly inflammatory. So you get all that pain because the body's trying to fix the tear and get rid of the nuclear herniation. You know, it just can't do it. And we have people for 40 years with this problem, 50 years. And they just live with the pain for 50 years because nobody could fix them. We can now fix them.
Next question comes from Gary on YouTube asking, why doesn't the herniation leak back out while waiting to heal up?
The herniation doesn't leak back out because, remember, the nuclear material, as we just mentioned a little while ago, is actually quite firm. It's firm and rubbery like that shrimp, all right? And so it won't leak out because it's not liquid, not like water, but it's firm. And if the patient does too much physical activity right after surgery, or bends or twists in a certain way, then yes, you will squeeze out more herniation. So they have to be careful during the healing process. We put all of our patients in a back brace around their waist. It's just a reminder, don't bend over and pick anything up. Don't lift anything heavy.
Next question comes from, forgive me if I'm pronouncing this wrong, Siwang Liu.
Siwang Liu.
And they're on YouTube, and they ask, can this also work for disc ideation and disc prolapse at L4, L5, and S1?
Yes, this surgery works perfectly well for disc degeneration and disc prolapse at L4-5, L5-S1. Mm-hmm.
And then the next, last but not least, comes from Michael on YouTube, and they asked, once the tube that surrounds the laser, is it in let me repeat. Once the tube that surrounds the laser is in the desired area, how do you navigate from left to right if the tube is sticking through the annulus?
Great question. So the question was, Dr. Duke, when you've got that tube that's stuck in the annular tear, how do you go left and right? We don't. We're not going left and right. We're actually just pulling the tube out through the tear. And as I pull the tube out through the tear, I zap away the herniation that's stuck in the tear. Now what you're seeing is I'm twisting the tube. So I'm not turning it, I'm twisting it. And I twist it to get it out, just because I don't want to pull it and suddenly it releases. So you want to kind of gradually pull it and twist it out.
No current questions on the live chat, but we do have an in-house question.
Oh yes.
Right next to us, Sanjay.
Sanjay.
Yes, doctor. So my question is regarding the...
Come on over here, Sanjay. Come on over here and join me in this camera.
So my question is, doctor, regarding the Duke plasma rhizotomy.
Mm-hmm.
So what instrument is currently being used for deadening the nerve?
Uh-huh.
And the other question is, if we are deadening the nerve, what is actually done on the nerve over there? So,
Okay, thank you. Good questions. All right, Sandra, you can sit back down. You need me?
I just want to recap something here.
I'm live. Give me a
Okay.
second. I'm almost done. All right, so Sanjay, who is going to be working on some special projects with me, is asking what's going on with this Duke plasma rhizotomy. He asked me what tool I'm using, which I'm not going to disclose, but he asked me, you know, how do you do the procedure? So you guys see this red nerve right here? That's called the medial branch of the dorsal ramus. It comes out of the neuroforamen up here, runs along at this groove between the transverse process and the facet, and it runs down along the lamina, innervates the joint below. Then you got the one below that runs up and innervates the facet joint. So you've got pain coming from the facet joint. So what I do is, to treat this facet joint here, I will deaden the pain nerve right here and right here, above and below the joint, at the joint and above the joint. And I use a probe, a special Duke spine probe, that basically burns the nerve right in this area. Does that make sense?
Yes.
All right, I think that's it.
We do have one more question. This just came up just now from Taz the Roam Runner 5150 on YouTube. And they said, I have scoliosis and a bulging disc and my bones are disintegrating. So what do you recommend for me, Doc?
Taz?
Taz, yeah.
T-A-Z.
T-A-Z.
I love the name Taz, short for Tasmanian, I suppose.
Yeah.
One of my favorite characters. Here's what you need done. First of all, since you have poor quality bone, I assume, you said deteriorating bone, it would be a really bad idea for you to have any kind of open back surgery, because they're going to want to put screws and rods, and that's going to, you have soft bone. So here's what they're going to do. There's two options. They're going to say to you, number one, don't do the surgery because you got soft bones, or I've got to make another house payment. You're going to need surgery with screws and rods, and we're going to have to go all the way up your spine and all the way down your spine because your bones are soft. Those are the two lines of reasoning, okay? They're both wrong. What you really need is the Duke laser disc repair to go in and just repair that one bulging disc that's causing your pain. You can find out if you're a candidate by using the link that Henry is about to put on the chat. It's mri.dukespine.com, and that will take you to our free MRI review. That will give you and I a chance to sit there face to face and talk for 10 minutes, and I can answer your questions. But most importantly, as for you and everybody else in the world, scoliosis doesn't cause pain. What causes pain is the facet joints and the discs. So I just need to figure out what your pain source is, but I can assure you it is not the scoliosis. I used to believe the same thing, and I used to do fusions for scoliosis for 20 years, and then I stopped doing them and just a laser, and it works to get rid of the pain. So do yourself a favor and come to Duke Spine Institute and get fixed the right way.
That is it.
All right, thanks for joining us. Our next patient is going to be a Duke laser disc repair, L3-4, L4-5, L5-S1, and no facet treatments or SI treatments. They just have disc pain. So you're welcome to join us.